And clearly, as we all know, important things to remember are our soft tissue handling. Like I said, I was tasked with P1 neck fractures, and these, broadly speaking, fall into 3 types. Type 1 is when you have the undisplaced neck fracture. Type 2 is when there has been a minimal amount of displacement, but you still got bone-on-bone contact. And type 3 is when the distal fragment has flipped around. They are actually much more common in children than in adults, and typically they come when a finger's been squashed in a door. In the adults, we tend to see them when a heavy object has fallen onto the hand, so they're more of a crush type injury. Like we said, the principles are to get them reduced, get them stable, which may or may not require some form of fixation, and then we need to get them moving. So it now brings us to the what would you do? I think broadly speaking here, the options that we're looking at are some form of a conservative management with a splint or taping. And then if we're going to fix them, considering either some form of a percutaneous wiring or an ORIF. So it's over to you now to decide what you want to do.
Can everyone see that poll? Yeah. It's anonymous, by the way, as well, so don't worry. Have a go.
So Emma, just let me know when we've got the poll results.
Yeah, no worries. I'm just, only 50% have voted so far. I'm hanging on.
We need to know exactly what fracture that we are treating here, because you just described several types of fractures. So we need to decide on what fracture we are actually treating.
I think let's consider the majority are the type 2 fractures.
And are they children or adults?
Let's go for adults.
Okay, I'm going to share the results. You can see that. So you've got mostly, oh, so I should say close reduction, percutaneous wire.
Okay.
Fab.
Good. Okay. Well, so let's go through the what would I do. As David has already pointed out, there are 3 different types. So we are mainly going to be considering the type 2, but I'll talk through the type 3. In the type 1, these are the ones that are undisplaced. And the first thing you need to do is you need to check whether or not they're stable. And that can be done under a digital block. And you want to put the PIPJ through from full extension down to 90 degrees of flexion. And if that distal fragment doesn't move and it's undisplaced, it's very reasonable to treat this in a splint. And I'll probably keep it in a splint for about 3 weeks with the IPJs extended. And you probably don't need to splint the MCPJs. In the type 2, which like we said are the most common, these need to be reduced. So ideally, again, can be done under a digital block, but can also be done under a regional block. And there are a couple of technical tips here which I think are important. There is a temptation with these injuries for people to yank the distal fragments, but that's not what you want to do. It's very gentle traction, because you can very easily turn a type 2 into a type 3. And the other thing is the distal fragment, again, wants gentle pressure, typically displaces dorsally, and then you obviously want to put a bit of gentle pressure into a palmar direction in order to reduce the fragment. Having done that, like I was saying beforehand, check the stability. And if it's unstable, which they typically do tend to be in the adult, then you'll need to fix it. And my preference would be to wire them. And I would fix them using my wire, passing it in an anterograde style. So I bring them in from the base of the proximal phalanx using either a 1.1 or a 1.2 millimeter K wire, carefully done under fluoroscopic guidance, and advancing it across the fracture and into the distal fragment. Remember, those distal fragments are small. They can be very easily broken up. And ideally, you don't want the wire passing into the PIPJ, because once you've then, once you start to get the joints moving, the wire can migrate distally, which you don't want. I cut the wire proximally, dress it, and then, like I say, you can move the IPJ. Maybe if you're a little bit concerned, you could splint it for the first week in the same way that you would do for the undisplaced. and I would get the wires out at 4 weeks.
But just before we go any further, Duncan was going to say something at this stage.
Yeah, sorry, thanks, Kate. Kate, one of my concerns with wiring anti-grade like that is I seem to have more problems with stiffness at the MCP joint after wiring that, and I'd be inclined to wire it retrograde, so you're capturing the small fragment. And I appreciate it's wiring the PIP joint, which is it's got a tendency to get stiff. But if you take the wires out early, it seems to be less problematic than my experience of wiring at the MCP joint.
Well, yeah, thanks, Duncan. I have to say my preference is not to do it because my concern is more of the PIPJ, and we'll come back to that. There's a case that I'm going to show you later on. We'll come back to that, but thank you. So the other option, I think, is to use some form of a plate. Oh, sorry, I should have mentioned regarding the type 3 fracture. These can be very difficult to reduce, and you might need a small mid-axial approach in order to reduce it. The benefit of doing that is that you can then advance the wire coming from a retrograde fashion, but bringing the wire in through the fracture site itself, bringing it out through the base of the proximal phalanx, reducing it, and then passing your wire, like I said, carefully into that distal fragment and stopping just in the subchondral bone. Remember that the distal fragment's blood supply comes in purely through those collateral ligaments, and so when you're doing the mid-axial approach, it's okay to take down the lateral band, but must preserve the collateral ligament. And that then leads me on to talking about fixing it. And I think there is an indication, particularly in those comminuted fractures, particularly if there has been any element of bone loss, especially if it's a late presentation, then I would use a hockey stick locking plate, again through a mid-axial approach. So my caveat here is that this is not my case before anyone shouts me down. But this is a case that I picked up from elsewhere that had been done at St Elsewhere, where it had been wired. This was coming in a retrograde style, and once the wires came out, this is then what happened. And this was a clinical picture. I have had permission from the patient to put these pictures out there, and I've got a little video to show you as well. Go. And I guess I thought it was important to include that because these fractures cannot be underestimated. They can go horribly wrong, as demonstrated, and that's a pretty poor clinical result for this patient. Thank you very much.
Thank you, Kate. I think on that last case, as well to remember that in adults, the blood supply to that area of the bone is quite poor, and they do tend to take a little longer to heal. So you may need to consider leaving the wires in for a bit longer. And the other comment I would have is that in children, I have never ever found it necessary to open these fractures in children. They will literally always, in acute or semi-acute situations, will reduce with a combination of pressure over distal fragments and flexion. And they can be wired quite easily by just flexing the joint down and driving a wire through the head of the phalanx, and you can actually withdraw the wire through the side of the proximal phalanx so that the wire protrudes through the side of the finger, leaving the trailing end of the wire in the subchondral bone so that the proximal phalangeal joint is not compromised and the soft tissues are not transfixed or prevented from moving. But they are quite tricky fractures to deal with, and you did present quite a diverse range of fractures there, so I'm sure that's been very interesting. Any more comments before we move on?
Nothing's come through yet, so we're happy to move on. Next speaker.
So next we have Ryan Trickett, who's now my colleague in Cardiff and has been for the last 6 years or so. Ryan did his advanced training post in Nottingham, and he also did a fellowship in Derby. And he's been a great support to me since he's been appointed. So Ryan, over to you.
Thanks, Dave. So I'm going to talk about transverse shaft fractures, which I guess, leading on from what Kate's just said, is just the same injury, but a bit more proximal. But there are some things really that I think are important in these injuries. The first is that, like long bone fractures in long bones, these are basically the result of a significant transfer of force. If we think about second degree levers, you've got your force in your fulcrum and then your load. So in a long bone such as the tibia, that's fairly easy to do, as we saw in the footballer in the last slide. But as our long bones get shorter, as we find in the hand, then that force either needs to be of a greater magnitude, or it needs to be more focused in its area of concentration in order to achieve that same transverse fracture pattern. So as soon as you see something that's transverse in the shaft, then I think you need to be thinking about a high mechanism of injury. Now, obviously in the hand, we don't see tackles like we do in the lower limb. And what they tend to be in the hand is a rapidly applied crush injury. I seem to commonly see these in scaffolders, whereby they get their finger caught between two scaffold tubes. But equally in kids, often the kitchen stools falling over and landing on the hand as it's on the floor is another classic one that we tend to see quite a bit of. So this is a case. This is a rigger who was doing some scaffolding. 43-year-old male sustained a blunt crush with a scaffold tube against some wood. A very small dorsal wound just at the level of that distal fragments fracture. Not obviously bleeding and not really contaminated. He had gloves on at work. So over to the pole again. What would you do? So we've got closed reduction and splint, closed reduction and percutaneous wire, closed reduction and intramedullary screw, and then RF either with a dorsal positioned plate or a plate positioned laterally, or something else that I don't even know about.
Half have voted. We'll just give it another few seconds.
Let's assume that the fracture is reducible closed.
Yeah. Yeah. Assuming the fracture can be reduced closed.
Okay, I'm going to publish the results.
Oh. It's interesting these. Hang on, let me just. So a third have gone for RF with a dorsal plate. Just under a third have gone for wiring, and a fifth have gone for intramedullary screw. And then the minority are going to treat conservatively, and a few will put a plate laterally. Okay, so carrying on with the case, he had an attempt at closed reduction in the emergency department, more so to take the pressure off the soft tissues rather than any sort of real attempt at treating this definitively. But you can see actually they've made a reasonable effort and managed to get it hooked back on. And it's not without the realms of possibility that you could perhaps treat this in a splint. And I know I've certainly worked in centres where that would be the case. In Cardiff, we tend to wire quite a lot of phalangeal shaft fractures. And our reasoning for that is we think it gives good, reliable results without a huge morbidity associated with it. And providing you can get these closed reduced, then they're reasonably straightforward to wire. We tend to wire them antegrade. I like to leave my wire entry point as far away from any joint or the bony sort of component of the injury as possible. So when we wire the MCP joint, we're obviously doing it with the finger flexed, and the wire has got a fair distance of soft tissue to travel through before it reaches anywhere near any joint or any bone. And I think that distance is important in not necessarily preventing infection, because we know a lot of these wires get infected superficially, but preventing any deep infection that can be later on problematic. So you can see the entry point of the wire there is just sort of dorsolateral in the base of the metacarpal. And we'll talk about that, because the entry point for these is really important. What we ideally try and do is leave the wire distally as lateral in the proximal phalanx as possible. There aren't any rotational forces from a muscle point of view that act on the phalanx. So you only really need to control rotation that occurs when people are going to knock their fingers. And if you're protecting them in a splint but letting the PIP joint move, then that's really quite unusual. But the entry point for wiring these is paramount, really. If you're too central and closer to the articular surface, then your wire, as in this case here, can end a little centrally distally. It's not a disaster, but you get a slightly better control the more lateral you leave it. If your entry point is too lateral, then you don't get as long a movement, as long a lever arm within the fracture distally, and you lose a bit of control. Your wire will always reflect off that cortex just there, and it will push it further here, which is why ideally your entry point is ideally just lateral to where this one is, and that would give you the opportunity to get the wire nicely all the way up into the lateral aspect of the phalangeal head distally. There are some other pitfalls. I know this is a thumb, so it's slightly different to the main thrust of today's debate, as it were. But I think one of the main pitfalls in these is underestimating the injury, and that's both from a soft tissue point of view. This was a closed injury, but it was a crush injury to the thumb. This was in a machine at work. The soft tissues all looked a little bit unhappy, as you might expect. And I couldn't really get a satisfactory close reduction with this. And on opening it, it was very clear straight away that everything had been stripped from that proximal phalanx. There was no periosteum. Other than the flexors and the neurovascular bundles, everything else was sort of transected at that level. So underestimating the soft tissue injury with these is a potential pitfall. And as with anything in the proximal phalanx, we need to be really cautious about those soft tissues. The other thing that's evident on this X-ray is underestimating the bony injury. With a crust mechanism, as these often are, there is that potential for some comminution at the fracture site, and you can see that on these plain films, but also some extension of the fracture lines. And this actually extended all the way down into the joint. And Nick Downing, who I think is registered, I'm not sure whether he's here today, but Nick Downing once told me that he was almost allergic to plating a phalanx. And I tend to try and avoid plates where I can. But in this situation, it was one of the few situations where it did require plating in order to get the stability, just because there was nothing offered from the soft tissues at all. So this is one of the few that I would plate. Something's flashing on my screen, which may well be that there's some questions. Yes, there is.
John is asked, why not use entry at open side rather than through web space? I'm not sure what he means by open side. If you look at site, then, well, you can use that if the fracture is open.
Why not use entry at open side? So is that for an open fracture, John, or? I'm not quite sure. I mean, when these are open, they're often a very small puncture, and that wouldn't necessarily.
I think the
Oh, okay. I tend not to like leaving the wires at the lateral border. So in the index, I tend not to like leaving them on the radial side nor on the ulnar side on the small finger. The soft tissues just don't seem to behave quite so well around the entry point, around the pin site there. I can't base that on anything other than they just tend not to look quite so good. So I always try and go into the web, and you can sound it out fairly easily. And it's just that fine tuning the entry point just before you finally fire your wire in that's important with these, I think.
I think just some comments on those. These transverse fractures of the proximal phalanx, they're often as a result of direct trauma, as you pointed out, and there may be some associated soft tissue damage, and they are quite often open, even if it's only a minor wound. And because there's only a small fracture surface, they do take longer to heal than these longer spiral fractures. And so that needs to be taken into consideration, not only in how you treat them, because obviously if you use a plate, then you're increasing the soft tissue damage and you're making more devascularization. And so you may be making the healing longer. But also if you do use wires, you may need to consider leaving the wires in for longer than you normally would. And some comments on the sort of site of injury of the wires. As long as you insert the wires with the MCP flex, as Ryan's pointed out, and you avoid transfixing the clutch ligament, which you should be able to do, then there isn't a problem at the metatarsophalangeal joint with regards to stiffness. You do have to splint the MCP in flexion afterwards, whilst the wire is in, first of all to prevent the MCP getting any stiffness, but also to stop the wire from irritating the pin site and increasing the likelihood of infection. But we've done hundreds of these now, and for various reasons, and as long as they're treated carefully and properly, MCP joint stiffness is not a problem. So thanks, Ryan. Any other comments before we move on?
Nothing else at this stage.
Great. Okay, so thanks, Ryan. So now we have Emma Ray, who is a consultant in Middlesbrough and has been there since 2014. She did her hand fellowship in Newcastle, which is obviously quite close to Middlesbrough. So over to you, Emma.
Thank you. That's excellent. Let me just put my presentation up here. Let me just make sure I'm sharing screen. Just 1 second. Is that sharing?
Not yet.
Not yet. Let me just try again. Press that button.
That's it.
Is that working? Brilliant. Fantastic. Sorry about that. Okay. Well, I'm going to discuss condylar fractures. Now, condylar fractures are a challenging injury to manage. And I think I will reiterate a lot of the points that have been made by my colleagues already about the general management of phalangeal fractures. The intra-articular nature of the condylar fractures leads to significant PIP joint stiffness and functional deficit. And that's why it's so important to try and adequately reduce the fractures. Now, the unicondylar fractures are more common than the bicondylar fractures, but the principles of management are exactly the same, and they're exactly as Kate said previously. We want to reduce the fracture, we want to hold the articular surface, and we want to, most importantly, enable early range of motion. Because the injury is already within the joint is already damaged, and therefore it is much more likely to become stiff. These can be managed non-operatively, they can be managed conservatively, but they have to be watched because they can displace. And I tend to do, if I'm going to manage them conservatively, if they're undisplaced, I will tend to take serial x-rays at 1, 2, and 3 weeks to ensure that there's been no movement in the fracture. So the majority will require operative intervention. And the aim of the operative intervention, as I've mentioned, is to try and bring the articular surfaces back together. But it's also about minimizing the soft tissue injury around the joint while you're fixing the fracture. Now, I tend to like to treat these percutaneously. or yeah, percutaneously rather than transcutaneously, but they can be treated with open fixation. There are a number of different approaches. Mid-lateral is probably my preferred choice if I do have to open them, but they can be fixed through a dorsal approach. Again, as Kate has mentioned already, taking care to protect the blood supply to the fragment by taking care to protect the collateral ligaments. When I reduce the fracture percutaneously, I tend to use a pointed reduction forceps in a eccentrically positioned, sort of eccentrically positioned on the proximal phalanx, the fracture site. And what you tend to find is that unicondylar fragment tends to slip rolally. So you have to position the pointed reduction forceps very carefully. Now, I don't tend to go through the skin. I tend to make a small incision and then dissect down onto the bone and then put the K-wire in, because you really do get one shot at the screw or the wire fixation. And if you're not careful and you haven't got the wire in the right position or the screw in the right position, you can further fracture the fragment. If you're going to use K-wires, oh, sorry, go ahead, Ryan.
I was just going to say, I mean, I find these really difficult to reduce close. So I would tend to not even try, actually, to be honest. I just tend to open these up with that mid-axillary approach that you said. And that gives me a bit more confidence then in knowing that my screw is going to go exactly where I want it to. Because like you say, you only get that one shot. The other thing I find is, as you said, with the percutaneous reduction, is that clamp is always in exactly where you want your screw to go. I tend to try and use my finger on the very apex of the fracture proximally, just to pinch it in, and then that gives me a bit more space to put my drill to drill my lag screw across. And you know, if I'm there and it's open, then I tend to put a screw because I think that's a bit more solid. But yeah, I can't do these closed.
Yeah, I mean, sorry, go ahead.
I can just say something. You know, there's two schools of thought here, and you will find people who will fix them percutaneously with wires, and Greg Giddens is an advocate of that. And then you will find people like myself and Ryan who will use a screw. But I think if you're going to treat them closed, wires should be used. I wouldn't use a screw percutaneously, because if you use a screw, the fracture has to be reduced absolutely accurately. And if it's not, then the screw will hold the fracture apart, and also you will risk fragmenting the piece. And the other thing I'd just like to say is that you mentioned treating them non-operatively. In our series that you highlighted was on the last slide, we found that all the undisplaced wounds in adults displaced. And the only ones that we had any success in treating non-operatively were in children. And it's only speculation, but we think that's probably because the periosteum in children is thicker. And so if it's undisplaced, it may protect the fracture from displacing. Anyway, carry on, Emma. Keep going. That's great.
Little bit of debate there. That's good. But if you are going to be using KYs, you need to be using two, because you can't control the fragment if you're only going to use one K-wire. I mean, I'm talking in the majority about unicondylar fractures here, because they're much more common than bicondylar. But it's the same principle if you've got a bicondylar fracture. The only difference is that you also have to fix the articular surface onto the metaphysis, and that can be done with screws or with wires. Again, I'm going to say it again, but preserve the articular fragment blood supply during the approach, because I think that's very, very important. So we're almost up to the what would you do, but in a second. So this is the case presentation. It's a 20-year-old lad who came off his push bike. Well, I think it was a mountain bike he came off, sustaining this injury, which was reduced in A&E, and he was left with that injury. Can you see that all right? So it's a closed injury. What would you do? So I've got options: treat non-operatively, which we've discussed, percutaneous wire fixation, percutaneous screw fixation, open reduction and screw fixation, or open reduction and wire fixation. I probably should have had another one on there as well, because Ryan had another, but I didn't.
These radiographs are taken in A&E, and it demonstrates one of the mistakes that's often made in A&E, where instead of requesting a radiograph of the joint that you're interested in, they are
Yeah.
getting a whole body on film. It really is very important to get an AP and a true axis of the joint that you're interested in.
Yeah, exactly. And also just to highlight that you need to get 3 views. So yeah, anyhow, so that's interesting. Screw fixation. Well, I'll show you what my colleague did, and then we can show you. Now, normally, as I say, I would try and reduce this percutaneously. However, this one in particular is so displaced that, surprise, surprise, it wouldn't go back into an adequate position with a closed method. It had actually flipped 180 degrees, so the articular surface was pointing proximally. So it needed to be open through a mid-axial approach, protecting the soft tissues and the collateral ligaments. And then 2 K wires replaced. This was only done 2 weeks ago, so we don't have any further x-rays, unfortunately, but this was done 2 weeks ago with percutaneous wires, which were cut just outside the skin.
Can I just ask, you said it was reduced open, but then you used percutaneous wire, which seems to be a bit of a paradox.
Yes, indeed. And I asked him why I used the percutaneous wires, and he said he had a good hold on them. So I don't know.
It's open.
I probably would have, to be honest, I would have open reduced it and put at least 1 screw, if not probably 2 screws in there.
It can't be both. It's either open or it's
exactly.
I just can't understand how you can't have it both ways. If it's open, it's open. It's not percutaneous, it's open.
Yeah.
Percutaneous means it's reduced closed and then you stick the wires to the skin.
No, exactly. So this one wasn't percutaneously reducible, so that's why it was open. So
Okay.
that one.
Percutaneous then.
And that is it, I think. I think that's me.
Thanks. There was just a question that came through. It's interesting to know what all of your thoughts are. The question was, would you CT this first?
No, I wouldn't.
Everyone's saying the same. No, 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 no.
I would have.
Excellent.
Graham, what do you see on a CT that you don't see on the x-rays or won't see when you open it?
Oh,
assuming that you're opening it, or are you fixing it closed?
if I'm undecided about whether I was going to, because I'd originally put that I was going to fix it percutaneously, but if I was in doubt as to whether or not I would be able to, it would just help me plan beforehand. It's always good to go in with a plan. I mean, I'm not a fan of seating, and I don't do it very often, but if I'm unsure as to the configuration, and especially if I'm not sure whether I'm going to open or fix it or not, I would have a lower threshold for doing a CT. Although, like you say, actually, I don't do CTs very often, like literally a handful a year, but I might have done with this one.
That's interesting, because I don't think I've ever CT'd one.
I think you'll find that when you've done a lot of these, you will then be able to correlate your operative findings that you expect with the radiograph without a CT. I've never found it ever necessary to get a CT for a condylar fracture. In fact, in some of the peripheral centres around us, people get CTs for fractures that I wouldn't dream of getting, and it delays the treatment by 2 weeks because they haven't ordered them as an urgent investigation. And then the fracture becomes untreatable because it's healed. And by the time it gets to us, it's 3 or 4 weeks down the line with a very unhelpful CT.
Yeah, we're very lucky. MRIs, it takes us months to get hold of one, but a CT we can get on the same day.
You can, but the trouble is that peripheral centres around you may not, and then they'll send them to you when they're healed with a very useless CT. So you have,
Yes.
you have to be a little bit careful about advocating that sort of treatment.
I was asked what I would do, but you're quite right, David. I won't disagree.
Okay, well, let's move on now. So now we come to Duncan Avis, who did a TIG fellowship in Birmingham, and he's been a consultant in Basel since 2016. And as he's pointed out, he's a keen road cyclist, which he has to be working in that unit. I'm not sure about the skiing. I think that goes along with Basingstoke as well. Anyway, over to you, Duncan.
Well, thanks very much. Let me just share my screen. So I'm going to spend a few minutes talking about spiral fractures and basing the discussion around a couple of cases, if I can. So just firstly, just a reminder about the mechanism of injury. Now, I work in Hampshire, and 9 times out of 10 in Hampshire, the mechanism of injury here is a horse rein related incident. Now, that might not be the same elsewhere, but it's a torsional injury causing a rotational deformity of the phalanx. Now, once the injury's happened, there's no real ongoing rotational forces, as Ryan mentioned earlier. And so the main deforming forces aren't necessarily the rotational load, but it's due to longitudinal instability of the fracture. So it's that longitudinal instability which results in ongoing displacement. And the only other thing that really comes into play is the intrinsic and extrinsic imbalance, which causes extension of the distal fragment and flexion of the proximal fragment. And that causes a bit of scissoring of the fracture in a spiral fracture like this. So if we just look at like a first case here, so this is a 41-year-old lady. It is, surprise, surprise, a horse-related injury. And she had a rotational deformity with the ring finger crossing over the little finger. Now, I think injuries like this, I don't have a poll for this one because I think it's ideally treated conservatively. And I would do a ring block. I would apply longitudinal traction if necessary, correct the rotational deformity. And with these ones, I buddy strap them and get them going early. I do get the hand therapists involved, and I do see them, and I see them for 2 reasons. One, to check that it's not displacing, so I will follow up in a week for an X-ray, but also to make sure that the patient A is moving their fingers and actually they are getting things going, but also not being too daft, complying with treatment, and not doing anything that's going to compromise their treatment. But I think hand therapy has a strong role in these injuries. That's her just after it's rotated and healed up nicely with no deformity and full range of motion. So this one is subtly different. Now you'll notice a plate on his middle phalanx. That's a historic thing. I don't know, that was not by me. I don't know what's happened there. But if we look at the proximal phalanx, I've got a poll for this one, Emma. If you're able to put that one up, what would you do? How would you treat this? This is a 50-year-old man. There's no horse-related injury in this, and it's 8 days old.
Okay, I'll just give it a little bit longer.
So, Duncan, are we assuming this is reducible?
Well, it's 8 days, so yeah, it might be.
With a bit of a shove.
With a bit of a shove.
So your first line treatment, I think.
Pardon?
So I would say, well, people have already voted now. I'd say, what would be your first line treatment? What
would be mine?
Your first, to everybody out there who's voting, but it's too late now. They voted.
Yeah.
Anyway, you're going to tell us anyway, aren't you?
I'm going to tell you now. Yes. My first line treatment would be to do this. Now, I really like the idea behind percutaneous screws. I think it sounds brilliant, but I don't think either I'm very good at it or it doesn't work particularly well in my hands. And either the drill gets caught in the soft tissues, I lose the drill hole, and I find the reduction unsatisfactory. So I've got a very low threshold for opening these fractures. And I would normally do it through a dorsal incision with a central tendon split. And I think the real key, if you're going to do any of these open, is good tissue handling, delicate tissue handling. And I would then reduce the fracture directly, and I would hold it with these either lag or positional screws. And the idea behind this is you get them moving straight away. There's no protruding metal work. Now, I appreciate there's good evidence that that K-wires would have the same result further on down the line. But again, I think the K-wires stick out, they snag, they get in the way. There's a slight infection risk with regards to the soft tissues. I think screws like this work very well. Now, you could plate it, but again, there's good evidence that the plate is more likely to cause problems with tendon adhesions. Certain fractures need a plate, but I think these ones are nicely fixed with simple screws like this. So this is my third case. And so this is slightly different, and you can see it's slightly different because it's displaced, and it's just a nice demonstration of the longitudinal instability here. And you can see this spike here around the PIP joint. And these ones, I would have a very low threshold for fixing straight off. I think these ones are difficult to control with splinting. And when you look at the CT scan, going back to our last discussion, so this you can see here on the, if you can see my cursor, you've got the AP view, you've got the volar view, and then the lateral views. And you can see that that's not an insignificant fragment of bone there. You can appreciate that that might interfere with the PIP joint. So this is an elegant way of fixing these. Now this is Ryan's case actually. I'd like to claim credit for it, but I can't. And again, using the same anti-grade wiring technique as Ryan described earlier, with a similar entry point, passing the wire into the bone, up until the fracture, then nicely reducing the fracture, and aiming the wire again, docking it into the subchondral bone on the side where that fracture tip is. Now, all this does is ensures maintenance of longitudinal stability. And again, once you eliminate that, you should be able to have a relatively stable fracture to allow early range of motion, and then early wire removal at 3 weeks or so. But sometimes, and as in this case, these fractures present late. And this lady was a horse-related injury who presented at 2.5 months with a stiff, painful PIP joint. And she just didn't have any deep flexion possible. And it's not an entirely uncommon scenario. And I think in that situation, 2.5 months down the line, the first thing is hand therapy and see what you can get. How far can you progress just with doing nothing other than targeted hand therapy? And once she'd plateaued, she got no further, needed deeper flexion and so took her to theatre and actually debrided this fragment. And again, through the middle-lateral approach, incising carefully through the transverse retinacular tissue. And the main thing is you've got to be really careful of the collateral ligaments. And it's possible, though, to debride all of this bone, again, being really careful of the collateral ligaments, and any volar bone, which is blocking flexion. And then the key afterwards, get them moving early on, and should do generally quite well. Now, on that note, I know David has a few points he'd like to raise with regards to that. And that's about all I have to say. So thank you very much. And if I pass you over back to David.
Oh, thank you, Jonathan. Yeah, so that last fracture that you put up, that's not an uncommon scenario. And it's important, I think, to not be heroic and try and reduce that at numerous weeks post-injury. It's better just to let the fracture completely consolidate, make sure it's completely solid, and then you can nibble off that blocking piece of bone. It's also important, as Duncan mentioned, is to recreate the fossa behind the condyle, the base of the middle phalanx to move into, so that you get full movement, full flexion of the PIP joint, which should flex to well past 90. Probably 110. And and you can do that with as long as you sort of strip off the flexing mechanism through your approach. You can get a burr, a burr in there to do that, which is very effective. You just have to be quite careful not to get that in contact with the soft tissues, but you usually get attached for the blunt end of that to protect those. Another thing I'd like to just mention that you alluded to earlier about percutaneous screws of spiral fractures, and I share your skepticism of that. If you use screws in a spiral fracture, the fracture has to be absolutely accurately reduced from paratum. Because if it's not perfectly reduced and you put screws in, the screws hold it apart, and then you've got the worst of all worlds. You haven't got a stable fixation enough to mobilize a fracture, and you've got a lot of screws in there as well, which can predispose to non-union if it's holding the fracture apart. So I think if you're going to use screws, it should be an open protection. So lovely, thank you, Duncan. So any comments before we move on? Oh, Gronia, what kind of burr? A small one. There's various sorts. There's a very small dental burr that you can use, very small round one, or there's a sort of like a conical one that you can use as well. I just use the smallest one they've got and just burr away until I've got my retrocondylar fossa recreated. This was also alluded to by Peter Burge in the seminar last week, if some of you were there. But it's important to make sure that you recreate that retrocondylar fossa to accommodate the base of the middle phalanx. Good. Any other comments before we move on?
David, just for me again, actually, what's your preference? What would you have done with a spiral fracture like that?
If I could reduce it,
Mm-hmm.
look, these days I would now drive a wire up from the base of the proximal phalanx up into the condyle. If I couldn't get it reduced, I would do a lateral approach, and then you have to decide which side you go from. And I think you look at the fracture, and the one you showed, there was the tip of the spiral, the distal tip of the spiral went just behind the condyle, and that's the place where you get soft tissue into position. And so it makes it difficult to produce. So that's the side you should approach it from. Also, the one you showed, that would give you an approach on the radial side of the finger, which is much easier than an ulnar approach. If you do a radial approach, that means you don't have to turn the hand over. So that means one less hand of your assistant is used up. Sometimes you do have to go from the ulnar side, and it's much more difficult. You have to turn the hand over, and someone's got to keep their hand on there to keep the hand turned over. But I do prefer a lateral approach, because then you can avoid violating that plane between the periosteum and the extensor mechanism, which does tend to lead to sticking down. And I know you can overcome that with some fairly vigorous therapy, but it does take a long time, and the patient has to be fairly well motivated to attend their therapy. So if you have a lateral approach, you get less of that. You still get it a bit, but you get it a bit less. Great. Okay. Anything else?
Yeah. Sorry. And just one thing I was going to add, because you thanks, David. But you also mentioned it's a technique course that Peter Burge mentioned last week, and that goes with those. He talked about it in the use of those P1 neck fractures, and particularly in kids when you get the finger jams. So it's a technique that can be used elsewhere as well.
Right. Yeah. And they often present somewhat late as well. So they come along after the finger's been squashed in the door. Maybe there hasn't been a wound, and then they come along, a month later, and the fracture's healed then. And my apologies to let. And Peter made this point as well. The one that he illustrated, he said that it's a bit early to do that because the callus haven't consolidated, and I leave it for several months because sometimes you do get a bit of remodeling, even though it's remote from the growth plate, the physis. You do get a bit of remodeling, so you can regain infections sometimes. But if it doesn't reappear, then you wait until the fracture is consolidated, and then you can. Okay, so now we're going to move on to Graham Chung, who's a consultant orthopedic surgeon in Liverpool, and he's been there since 2011. And his interests are eating and watching what he calls are the best team in the world, presumably a Merseyside team, and I assume that means Everton. Over to you, Graham. You're muted. That's a good job, isn't it?
Yeah, thanks for that, David. As Bill Shankly once said, there are two teams in Liverpool, two teams in Merseyside, Liverpool and Liverpool reserves. Has that worked?
Yeah.
Cool. All right, so there's one thing about being given this topic, because when I first heard that David and Ryan were part of the panel, the first paper I came across was David and Ryan's, more of which later. So, base of proximal phalanxes. I haven't put a poll up for this because I think most people would agree that we should treat these conservatively. I think you can see that there's a little undisplaced transverse fracture. This was in a 56-year-old patient who'd got his fingers caught in a dog lead, undisplaced fracture. And people have to decide how they're going to treat this conservatively, because if left to their own devices, this can happen. It's a different patient, but the principle's the same. And I think the panel would agree that we need to keep an eye on them, because they can go on to deform. They get this palmar apex volar displacement and angulation, so that in theory the extensor mechanism, or the intrinsics, which start as a flexor, become an extender perhaps, and then become you then go on to get extension at the MCP joints and pseudocloring with flexion at each of the IP joints. At least that's what Mr. Shewring's paper said. I've always thought that it's just because the bone's a little bit bent, and you just get some imbalancing of the flexors and extensors. Either way, this pattern of pseudocloring and hyperextension of the proximal phalanx is a well-recognized one. And there's two treatment options: either neighbor strapping or some sort of dorsal blocking splint. This is also from David and Ryan's paper. I think, and the panel would mostly agree, that if you're going to treat these conservatively, you do need to keep an eye on them, because they can go on to develop pseudocloring. My personal preference is to use a dorsal blocking plaster. This is to defunction the intrinsics and stop people from extending at the fracture site, but allowing full active flexion. And it means I don't have to trouble the therapist, which they can't always get the patient to do this on the same day. So it's the same plaster I put on for my flexor tendon repairs. This one I do have a poll for. So this is a 46-year-old chap, fallen outstretched hand, and sustained this displaced fracture. See what you do. Let me know what you'd think.
Okay, I'll just give it a little bit longer. Okay, there we go.
Close reduction of percutaneous wiring. Cool. For those, I've K-wiring has long been a popular choice, popularized by Eaton and Belsky, and it was the Eaton-Belsky which was used to treat this the earlier fracture that I showed. This was done by one of my colleagues. Some older surgeons still seem to like it. I personally think it's hideous. I find that often extensors get tethered, and even if the wire isn't through the extensor mechanism, the joints get horribly stiff, and this patient was horribly stiff afterwards. The R equals N equals 1, and it doesn't prove anything, but in principle, I hate it. And going through the metacarpal head just seems unnecessary. And that patient's still has a degree of deformity, and she continues to do horribly, and her MCP joints are horribly stiff. The wires were only in for 3 weeks, but she's really struggled to get it going. Other papers would suggest that cross K wires from either side of the metacarpal head are better than going through the joints, and most people would like to do that. Others would, and some of our panel might agree, that actually a single wire would be better. I probably should leave discussion about that with Mr. Shewring and Trickett. I've personally always hated K wires around the MCP joint. Much like Duncan, I often find that the patients get stiff, and it could be that I'm just crap at doing them, but I'm willing to take that on board, and I usually treat these fractures with the dorsal blocking plaster and serial X-rays. Although very recently, and I'm very, very conservative with a small c, but very recently, I have been a bit more, perhaps very adventurous. My issues with K-wires is the extensor mechanisms all around the finger and gets very close to the MCP joint. And there was this paper last year which showed that it doesn't matter where you put the wires, you will pretty much always go through a bit of the extensor mechanism and tether it. Now, it may or may not be important, and some of my senior colleagues may find this controversial, but I do find that if you do wire them, there's always the risk that the tendons will get stuck down, and they'll require a fair bit of physiotherapy to get going. So as much as I mostly do treat these conservatively, you can use internal fixation. I don't use plate and screws, but I have very occasionally, as Del Pignal suggested, put some intramedullary screws in. This is a paper from Del Pignal's paper, and he's put a whole load of screws in for a severe crush injury. I mean, I think it doesn't matter what you do to this. This is just a hideous injury. I think whatever you do is reasonable. Geeson showed that in phalangeal fractures, that intramedullary screws do well. They allow early mobilization and good reduction, mostly with a very low complication rate. Now, for those who were at the last webinar, a lot of people stuck their hands up and said, well, if you go through the joints, you're destroying some of the articular cartilage. And that had always been my misgiving about the procedure. And so I felt reassured when I read this paper by Urban Schitz, who actually pointed out that actually it's actually a very small percentage of the joint surface, especially if you go from in an antigrade fashion, rather less so if you go retrograde. So if you go in antigrade fashion, you're only chewing up 5% of the articular cartilage, 8% in the little finger, and that's in the middle phalanx. It's less for the proximal phalanx. If you go retrograde in a phalanx, you're talking at 11 to 13%, which is a bit more, but probably not that much. What else do people dislike about intramedullary screws? Oh, that's a technical tip. I've put that in the wrong place. People worry about the cost. Wires are very, very cheap. Screws are not that cheap. I mean, 80 to 150 pounds, depending on whose screw you use. In the grand scheme of things, probably not that much. as a procedure, it doesn't take that long to do. It now takes me about 20 minutes, as long as it's easy to do. If that, and that's getting a trainee to do it. And the patients don't need any physiotherapy. You don't have to put them in a plaster or splint afterwards. It's not all bad, and it's worth a consideration.
So, Graham, would you actually advocate using one of these intramedullary screws for the fracture that you've been discussing, which is a metaphyseal base of proximal phalangeal fracture? And something that just struck me is that you've obviously fretted about a K-wire passing through the head of the metacarpal. But you're not averse to shoving a large screw through the articular surface of the base of the proximal phalanx, which seems to be a bit of a paradox to me. To use one of these screws for a metaphyseal fracture of the base of the proximal phalanx.
Yeah.
You can see they've got their uses, and it's a useful tool. Example of, that case that you showed of Paco Pinal, with those very severe fractures, multiple fractures affecting multiple bones and multiple digits, which were presumably open. That was very, that's a very salient use for them. But for a metaphyseal fracture base of the proximal phalanx.
Yeah, I mean, I get your point. I mean, the thing I like about the intramedullary screws is that you don't have to immobilize the patients afterwards. And actually, if you get because it's not tethered, and so because you can mobilize them early, I don't think sticking a 3mm across hole it's 5% of the joint surface, and the hole will fill up with fibro cartilage, and they can mobilize early.
So why do you describe the passage of a wire across the metacarpal head as a horrible thing in that context?
Oh, because it causes because of the immobilization, as opposed to the immobilization, as opposed to stick.
In case you showed, the metacarpal phalangeal joint was flexed at about 45 degrees, which is a recipe for stiffness. It had to be flexed at 90 or pretty close to that. So that's a problem with the technique.
Yeah, no, absolutely. I agree. Like I said, it wasn't my technique, but I was using it as a case in point as a reason why I don't like it, is that it's not foolproof enough.
Ryan, what do you think? Is he still there?
Yeah, I'm still here. I mean,
Kind of boredom.
I tend to wire these antigrade. I know. Is Duncan still here? Duncan gone?
Yeah, still here.
You wire these antigrade as well, don't you?
Well, yeah, I think despite what I said about having reservations about wiring around the MCP joint, as Graham's kind of chatted about earlier, I think these are one of my absolute indications for doing so. And I generally put one, maybe two wires in. And I think my reason for that is I think people generally do very badly if they are left with a malunion, again, as Graham was saying, and I think they're really quite prone to it because of the flexion of the proximal fragment. So yeah, I in this case, I definitely do.
Yeah, I think this is a quick and easy thing, which we do under local anaesthetic, and probably can do it a bit quicker than an IM wire. And it's just making sure that you put the wire in with the MCP joint flexed, and as long as you do, I've not run into any problems.
You need to make sure that they see the therapist very properly. Another point that I'd like to something that Graham mentioned is that he has difficulty in getting his patients seen by therapists on the same day, and that really illustrates if you're providing a fairly extensive acute fracture service for the hand, that illustrates the importance of having the therapist with you in clinic. It's such a big advantage having the therapist with you in clinic, so that when they come back from theatre, you take them over to the therapist and you can discuss with them exactly what you want them to do, and it's done on the day. You don't have to wait for them to be called in or whatever.
Oh, so that sort of thing we do have, and actually our post-ops are all seen by hand therapists, and we do have therapists within clinic. But sometimes, if it's really busy, they don't have enough splinting slots for all of the patients that we provide for them. So as an alternative, I'll stick a back slab on.
Means you need more therapists.
we could all do with more therapists. Yes.
How many have you got?
We usually have 2 actually with us in full time in clinic, and there's usually another 2 round within in the therapies department.
We've got about 10 in Cardiff, and altogether we've got about 18 spread across 2 sites. Some doing elective, some doing trauma, and some doing both.
Yeah. We need more therapists.
Yeah. Get on it. Great. Any other comments?
So I think that is really important, because essentially all of this is a trade-off between, you know, we can talk about all the various different techniques, and we can talk about what each of us is comfortable doing, but it has to be within the context of the unit that you're providing this service. And, you know, particularly if you're providing a service that's quite widespread, how compliant patients are going to be.
Yes, I agree with that completely. That's a very good point, Kate. So before we wrap up, why don't we just go around the panel and see if anyone's got any burning points they want to make. So Graham, why don't we start with you, since you just
Yeah, I think my learning point would be try not to disagree with Mr. Shewring. You're going on a webinar. And it doesn't matter how well you've read his paper, he knows it better.
Okay, Duncan?
Well, I think there seems to be a fairly strong consensus amongst the panel with regard to the anti-grade wiring. And so I think, like you're saying, if you maybe do it properly, ensure early mobilization, ensure that it's done in a flex position, you may convert me to that. So I'll definitely give it a go. I think there's a lot of logic behind it. And I like the rationale. So yeah, I think that would be what I would take home.
Emery?
Hi. No, I found the discussion about the base of the proximal phalanx management very interesting. We tend to treat non-operatively, but some of my colleagues will wire, and now one of my colleagues will also put an intramedullary screw. He's just started doing that. So it is interesting. I mean, we have 4 hand therapists. So I totally agree with what's been said about having, that's only half the treatment. If, you know, doing the surgery is half the treatment, the rest of the treatment is the rehab. And you have to tailor what you do sometimes to what you have available for the rehab side of things as well.
Yeah, I've always sort of preached the edict that you can do a fairly rubbish operation, but if you've got really good therapy, you can salvage good results. If you do a great operation, you've got rubbish therapy, and you'll still end up with a pretty poor result.
Yeah.
Probably one of the more important cogs in the wheel. Ryan?
I was just going to respond to Will on the chat, Will Mason on the chat, who's just asked. He rarely buries his wires if they're only in for 3 to 4 weeks, but often buries them around the MCP joint. The only wires I tend to bury now are ones that cross the PIP joint if I'm doing a PIP fracture dislocation. We have looked at about 600 odd wires that we've done consecutively in Cardiff, and shown a very, very low serious infection rate, but you know, a reasonable 8%, which is about in line with the rest of the literature. Rate of slightly red pin sites that you might give them some low dose antibiotics for, and haven't found a huge problem with nurse-led weekly pin site care, regardless of where it is. Obviously, and that's just in the fingers and in the metacarpals and the hand, not down into the wrist. So we tend to leave all of ours proud and just keep an eye on them, and we haven't seen a huge problem.
That might be because you've got the weekly nurse-led pin site clinic, which we don't have anything, even resembling any sort of. Yeah, I'm jealous now, Brian.
Well, you're young. I set this up when I was first a consultant, and it's been going for 20 odd years now. So they're very good at
John.
and it's just one of those things that lends itself for nurse-led things. It's
Yeah.
such a thing, they get used to it very quickly. They're very good at it. They're very good at picking up on any problems. They're very good at dishing out advice to patients, and they like doing it. It's a sort of practical thing that they like doing. So it's it's something I would promote.
Well, that's something else I'll take away then. Watch this space, Middlesbrough.
With regards to K-wire burying, the only ones that I think, well, in Cardiff, the only ones that we actually always bury are when we put wires in for scapular unit dissociations, because they have to be in for so long, for 8 weeks or so. So they're bent over, the skin's sewn over the top, and then they have a local anaesthetic to remove them in about 8 weeks or so. Am I right, Ryan? So
Yeah.
that brings us back to Kate. Any final comments, Kate?
We've got a nurse dressing clinic. We've also got an excellent therapy department at Derby. So who knows, probably most of my patients are being salvaged by both of those things, but they are important. So as I said earlier, I think you need to consider what techniques you're comfortable with, what techniques work in your hands. And we've, out of a panel of however many of us today, we've already demonstrated there are differences. But then for me, the take home message is you've got to get these moving soon. And if you're doing something where you can't do that, you're not doing the right thing.
Yeah, great. Well, thank you very much, everybody. So thanks for everybody's contributions and providing all those cases and discussion points. I found it really interesting. I think the final comment from me would be, as everybody's pointed out, there are lots of ways to treat these things, and you do whatever you're comfortable with, and you do whatever you're good at, and do whatever your resources indicate that that you should be, that you've got the capacity for. But the most important thing of all is don't make the patient worse. Be honest with this, because we've all done it. We've all done things we've regretted to make the patient worse. Always make sure that you're honest with yourself and learn from it, and try and anticipate. Could I be making the patient worse by doing this? If that's the case, you need to think long and hard about what exactly should be done. Good. So,
just hand back to me, just to say thank you very much to our panel there. I know you put a lot of time into those presentations. I really appreciate that. And also to our chairman, Mr. Shewring, we appreciate you taking your time as well this evening. If I could just ask the audience, when I send the certificates, if you'd kindly just give us some feedback. We can't make these things better without that. So we again appreciate that. It's been quite difficult to, all of our courses have been cancelled, postponed. So we're trying to work around still doing some training. So this is the next best thing to real life. So appreciate everyone for turning up tonight. And thank you very much.
Lovely. Thanks, Emma.
Thanks, Emma. Cheerio.
Thank you. Bye-bye.